Hello everyone, welcome to Patho Excellence. In this endometrial pathology video series, today's topic is systematic reporting approach to endometrial biopsy. In this topic, we will learn indications of biopsy, adequacy, artifacts, pitfalls, irregular secretory endometrium, temporal variations, important definition to describe glands, and most important step-by-step microscopic approach to endometrial biopsy. What are the indications for endometrial biopsy? Most common is abnormal uterine bleeding. In postmenopausal patient, to rule out endometrial carcinoma, for infertility evaluation, follow-up of hormonal therapy or tamoxifen therapy, suspicion of endometrial hyperplasia or carcinoma, for investigation of atypical glandular cells on pap smear, assessment after endometrial ablation and treatment, and evaluation of recurrent pregnancy loss. Rarely used now because it is mostly replaced by molecular methods. Now, what are the adequacy criteria for sample? The volume of the sample depends on the procedure performed to obtain the specimen, either Pepel biopsy or curettage biopsy. And it also depends on hormonal status of the patient, whether patient is premenopausal, postmenopausal, or postmenopausal taking hormones. It is considered adequate if glands and stroma present or tissue sufficient to evaluate cycle, phase, or pathology, and at least 1 mm of intact tissue recommended. If mitotic figures only one is present, will confirm proliferative phase endometrium, while secretory vacuoles will confirm secretory phase endometrium. It is considered inadequate if scant material, only blood, mucus or endocervical or vaginal tissue is there, predominantly necrotic or autolyzed tissue, or only glands are present and no stone. Some common artifacts includes Rush artifact, pottery artifact, autolysis, and fragmentation. Let's see one by one. These are due to presence of clots or blood obscuring pathological detail. So here in this section, we can see presence of blood clots and only faintly stained some glands are visible. These are cervical glands. Here we can see no endometrial glands are seen. So in this, it can be overcome using a lysis buffer or ethanol solution before applying conventional fixation techniques. Second artifact due to insufflation procedure during hysteroscopy or suction evacuation introducing air into tissue. This leads to vacuolated spaces in blood or tissue mimicking fat vacuoles. This is called pseudolipomatosis. And these artifacts should not be mistaken for adipose tissue, and this can lead to overdiagnosis of uterine perforation, which is life-threatening condition. In this section B, we can appreciate pseudolipomatosis. Here, fat-like spaces or clear vacuoles are visible with areas of hemorrhage and some glandular tissue. So this is called pseudolipomatosis, and it should not be confused with adipose tissue. In this section, this is true adipose tissue in endometrial biopsy, and always represent omentum or extrauterine pelvic soft tissue, and it indicates perforation of the uterus. Third, cervical contaminants. These are common, and strips of bland squamous or mucinous epithelium and irregular pools of extracellular mucin are common. So endocervical glands with metaplasia or hyperplasia, yield complex patterns, but these elements are cytologically bland and usually blend into more typical cervical epithelium. Rarely, an endometrial biopsy may also reveal a admixture of fragments of tissue from cervical dysplasia or carcinoma, and there may be chances of having fallopian tube mucosa in the biopsy. So here in this section A, we can appreciate endocervical tissue having squamous metaplasia. In section B, endocervical tissue, which we can appreciate the lining of endocervical epithelium, which contains abundant lymphocytes and plasma cells. So this should not be mistaken for chronic endometritis. Here in this section, these are the endometrial glands, fragmented, some intact, with excessive amount of mucus present and part of cervical glandular tissue. Fourth is traumatic disruption or fragmentation of the stroma. This may result in glands appearing more crowded than normal or may be separated by clear space or blood. So careful examination will rule out an erroneous diagnosis of hyperplasia. Now biopsy trauma compressing glands leads to telescoping effect, or it also called a gland within gland appearance. And here this complicated pattern can lead to an initial impression of complex hyperplasia. But here, if you see carefully, each glandular structure is surrounded by a rim of normal glandular epithelium and thereby discounting the diagnosis of hyperplasia. We will see in next slide. Now, poor or delayed fixation of specimen, most commonly seen in hysterectomy specimen. In this, there is retraction of the stroma from the glands, leaving a halo-like space around the glands, and we can overcome this effect by injecting formalin through external cervical os into the cavity or bivalving the specimen prior to immersion in formalin. So by this we can reduce autolytic effect in this specimen. So here we can appreciate a gland and gland within it. So this is called telescopic artifact. So this is telescoping artifact and it is also called gland in gland change, and this is due to biopsy procedure. This is retraction of stroma around glands to create an artifactual halo effect. This is again fragmentation which is artifactual. Here these normal proliferative glands are separated from the stroma or detached from the stroma, and they are increased in number, but these are artifactual fragmentation. Now, what are the pitfalls? So first, absence of surface epithelium compromises the interpretation. So whenever we see the slide, first identify the surface epithelium because it is the best for interpretation. Second, tissue from the lower uterine segment or basalis is not satisfactory. Here you can appreciate this is the surface epithelium. This is a thin out endometrium. Here weak proliferative gland, and this is the basalis layer. And here typically thick walled blood vessels are there. So this should not be considered or misconstrued as element of polyp. Third, straight tubular glands beneath the surface are normal, and it's not a sign of irregularity in maturation in the late secretory phase. Fourth, A substantial number of glands must show subnuclear vacuoles or sufficient evidence of ovulation. Scattered subnuclear vacuoles in glands are not sufficient for dating. Then, presence of secretions in glandular lumen does not indicate secretory endometrium because proliferative or hyperplastic and neoplastic glands can contain luminal secretion. So most important thing is to see glands and nuclear changes to determine the presence or absence of secretory change. 6th point, focal glandular crowding caused by tangential sectioning. And like it can occur in proliferative or secretory endometrium. So this artifact can show back-to-back arrangement of the gland. So here we can appreciate artificial crowding of the gland on this right side, and here this is the normal part of the endometrium. Ki67 proliferation index will assess the glands in secretory endometrium typically show minimal to no proliferative activity when compared to hyperplasia. 7th point is focal cystic glands or non-reactive glands can occur in normal endometrium and have no significance. 8th point, stromal edema is normal in all stages of the secretory phase. However, maximum during the mid-secretory stage. 9th point is identifying very early pregnancy based on endometrial changes alone is very difficult. So, apparent hypersecretory late secretory phase glands with vacuolated cytoplasm usually are a variation of the normal development and it do not indicate early pregnancy. In case of pre-decidual change, we must see around the spiral arteries for the identification. Then 11th point, infiltrating leukocytes are normally become prominent in the stroma at the late secretory phase. So this do not represent inflammation. If the tissue is difficult to interpret because of apparent discordance in features, there may be possibility of chronic endometritis or polyp. And the endometrial phase cannot be accurately assigned when there is polyp, inflammation or other abnormalities are present. Now, what are the causes of irregular secretory endometrium which are undateable? So, some hormone effects include anovulation means excessive estrogen, changes previously known as luteal phase defect. Second, persistent corpus luteum, exogenous hormones, pregnancy. Some structural or pathological lesions include polyps, leiomyoma, chronic inflammation, hyperplasia, carcinoma, atrophy, or sometimes sampling problems like fragmentation or lack of surface epithelium. Now, histologically, findings are non-specific but frequently include irregular glandular and stromal maturation with a large variation in a pattern of endometrial development from field to field. For example, some areas may show early secretory change while other areas show foci of pre-decidua consistent with mid to late secretory phase. So this is called irregularly secretory endometrium. Now clinically, this discordant endometrial development is thought to contribute to a non-receptive endometrium which might cause implantation failure. Now some important temporal variations according to age, like prior to the onset of menarche, the endometrial cavity is lined by cuboidal epithelium with claps dipping into the spindly stroma. With the onset of puberty, estrogenic influences initiate endometrial proliferation to commence the cyclical changes. And in the early phase of menarche, ovulation is not regular and usually anovulatory bleeding is frequent. In newborn child, there is sometimes proliferative activity is seen. This is due to maternal hormonal effect. Here, this is a section showing endometrium in a 3-year-old girl showing simple endometrial pattern with surface epithelium and clefts dipping into the spindly stroma. This section shows endometrium in a 10-year-old girl. Here, there is beginning of glandular development. Now, important terminology to describe glands, whether it is atrophic, inactive, or weak proliferative. So, what is atrophic endometrium? This is a single layered mitotically inactive glandular epithelium with scant cytoplasm in postmenopausal womb. So, these are very small, cystically dilated glands and cuboidal to columnar epithelium. Inactive endometrium. It is somewhat similar histological features but with the increased cytoplasm and retention of formed glands in biopsy. This feature of exogenous hormonal effect in premenopausal women. So inactive glands are small glands, flattened epithelium and minimal proliferation. In weak proliferative, mild glandular proliferation but no mitosis. So this term is reserved for cases that most closely resemble proliferative endometrium with pseudostratified columnar epithelium and inconspicuous mitotic activity seen in perimenopausal or postmenopausal women with abnormal uterine bleeding. So, mild glandular proliferation but no mitosis, early in cycle or low estrogen. Here, during these features, we have to correlate with clinical history, including age, menopausal status, and hormonal therapy. These are the atrophic glands. These are the cystically dilated glands, very thin layered epithelium, either flattened or cuboidal epithelium. This section shows inactive glands where cuboidal to no columnar epithelium and weak proliferative where the gland shows pseudostratification but very inconspicuous or no mitotic activity. So, whenever we see different types of glands, we have to term it according to the features of the gland. Now, this is important step-by-step approach during microscopy. So, practical tips to judge ratio of gland to stroma. So, first of all, scan on low power view, 4x or 10x view. Here you see overall architecture matters more than nuclear details. Now look at representative fields, not just one area because biopsy may fragment it. So try to identify tissue with surface epithelium. Now to judge the gland to stroma ratio compared to normal endometrial with proliferative phase in mind with lots of stromal blue background. If you see glands almost touching each other with minimal stroma, think hyperplasia or carcinoma. If stroma is abundant and glands are evenly spaced, then it is likely a normal cycling endometrium. So gland to stroma ratio, normally it is around 1:1. Here there is glands plus abundant stroma, and these are the evenly spaced tubular glands and abular stroma. So here we can diagrammatically see glands with stroma are equally present. Now simple hyperplasia and complex hyperplasia, it is showing 2:1 and 3:1 gland to stroma ratio. Here more glands are there and still separated by stroma. Increased glandular crowding, mild architectural change, and no atypia. Right? So this is simple hyperplasia. Now complex, it is more than or equal to 3:1 gland stroma ratio, crowded glands, and minimal stroma. There is back-to-back glands arrangement, and here we have to see cytological atypia. Now endometrial carcinoma, virtually no stroma showing more than 3:1 gland to stroma ratio. There is solid glands, cribriform glands with minimal or no stroma, overlapping of glands, and atypia. So this is the normal endometrium, 1:1, 2:2 to 3:1 is hyperplasia, and stroma is reduced and gland to stroma ratio is increased. So this is evenly spaced normal proliferative endometrial glands. In hyperplasia, we can see less stroma but still visible stroma, back-to-back arrangement of glands. This is complex hyperplasia. Stroma is reduced but still visible, some angulated gland, and back-to-back arrangement. Here gland to stroma ratio is increased. This is hyperplasia with atypia, where there is gland to stroma ratio increased, very little stroma visible, and some atypia in the glands with outpouching or angulated glands. Here in this section, we can compare normal endometrial glands with the part of endometrial carcinoma, where gland to stroma ratio is no at all stroma and increased number of the glands. Now, why endometrial biopsy is done? We have seen common clinical queries in the form of indications of the biopsy. Now, important is systematic reporting approach. So first, as we have seen adequacy criteria, so we have to write down whether it is adequate, inadequate, scant, or fragmented. So for example, adequate endometrial tissue with glands and stroma present. Second, menstrual phase dating if applicable, like whether it is proliferative, secretory, atrophic, or inconclusive. For example, endometrium in proliferative phase correlating with cycle day 10 to 14. Third important thing is gland to stroma ratio. So it is quantitative estimate. So normal, as we have already discussed, 1:1 or increased. So for example, gland to stroma ratio is around 2:1 with focal crowding. Now, the architectural pattern, whether the simple tubular glands or complex branching glands or back-to-back arrangement or cribriform. So we have to write down, for example, complex glands without obvious cytological atypia. Now fifth is cytological atypia, whether it is present or absent. If present, whether it is mild, moderate, or severe. For example, no cytologic atypia is identified. and other findings like polyps, cystic atrophy, metaplasia, inflammation, necrosis, foreign material if present, then you have to write down. For example, cystically dilated glands with inactive epithelium. If you appreciate artifacts, then write down whether it is crush or fragmentation or thermal damage. For example, fragmentation artifact present, interpretation should be correlated clinically. So final impression or diagnosis must include normal proliferative endometrium or secretory endometrium or hyperplasia without atypia, atypical hyperplasia or carcinoma, whether if present type and grade if possible, or other benign lesions like polyp or atrophy. So this is an example of final report statement like adequate endometrial biopsy showing proliferative endometrium, write down gland to stroma ratio with no evidence of hyperplasia or malignancy, no ATP identified, fragmentation artifact noted but does not significantly impair interpretation, and clinical correlation recommended. So reminder of important reporting points. Always correlate with clinical indication. Consider age, menopausal status and hormonal therapy. Comment on adequacy of the tissue. Mention any artifact clearly. Use standardized terminology and avoid vague terms like non-specific without explanation. So I hope this will help in endometrial biopsy interpretation. So if you like this session, then don't forget to like, share and subscribe. And I also appreciate your comment. So thank you, and next episode will be of abnormal uterine bleeding. Stay tuned.